Thank you very much, Professor Righetti, for your kind invitation, and also thanks to the Scientific Committee for giving me this topic, which is very dear to me. Femtosecond cataract surgery and capsulorhexis, which is a very important step in cataract surgery, affecting the refractive outcome and the effect of a multifocal or monofocal lens. In humans, Nagy in Budapest used femto laser in cataract surgery. The wavelength is very close to the infrared wavelength, and the effect on tissues is photodisruption. Here is a list of all the lasers we use in clinical practice: YAG laser, argon laser, or excimer laser. The photodisruptive power is due to the fact that plasma bubbles form, they dilate, they expand, and very quickly separate the tissues. The combination of all these bubbles causes a cleavage plane. In 2015, almost 8% of cataract surgery was performed with femto laser. In Italy, 1%. In the rest of the world, 2%. In the States, 8%. There are 4 or 5 machines only in the whole of Italy. It's expected that there will be a 15% increase in the next 5 years. These are the currently available machines, 5 different platforms with all the different features you can see. The docking is the attachment of the laser tube to the eye bulb. And then all these machines have OCT for anatomical assessment. You may have a built-in bed or not. This is the laser I use in Modena, thanks to a university donation. I will have it available for 3 years. It's wheeled. It can be taken to one place or the other. You don't really have to move patients, as in the case of other laser machines. On the right, you see that we have applied the tray that we fill with water because there is a liquid interface. Then what we do is position the laser tube for docking purposes. On the left, you have a conventional technique. Instead, in the laser type of surgery, you can plan micro incisions, biplanar, monoplanar. You can plan the length of the incision in capsulotomy, and also the fragmentation pattern. We've removed the capsule here, and the lens is fragmented already into 8 slices. We had to change the technique, the phacoemulsification technique, a little bit. I use the so-called manual technique. I don't use the sleeve. I use a separate infusion so as to make 1.4 millimeter micro incisions. 1.4 millimeters is our procedure, and then with the new lenses, we can implant them at 1.4 millimeters. They are hydrophilic lenses going through very small incisions. After this first step, you go on as in common cataract surgery. I aspirated, then introduced the lens through these micro incisions, which sutured with water. With laser, you can do corneal incisions of different types, then capsulotomy and nuclear fragmentation. There are also lasers that form cubes at the center to dissolve the nucleus better. Let's see capsulotomy. It can be performed in various ways. This is with a bent insulin needle. This is another example with capsulorhexis forceps. This is congenital cataract. In this case, we stain the capsule. I'm aspirating the capsule now. You pull it with the capsulorhexis forceps. Alternatively, you can use the second incision to reach capsulorhexis in a more difficult spot. More recently, I started using this ring. It's called Verus. It's a silicone ring. It sort of guides you through the manual capsulorhexis. You introduce it in the incisions. You use a push and pull type of forceps, but you can also use other hooks. You place it in the anterior chamber. You inject viscoelastic material, also to push it on the lens so that some form of imprint is left, and then you use the edge of the ring to make the capsulorhexis as circular and homogeneous as possible. This is capsulotomy, when you remove the capsule after femtolaser surgery. It's very easy and quick to do. You have to be careful because bridges may form. If the laser was not able to mark it completely to perform perfect capsulotomy, then it may be somehow risky. Here is another example of capsule removal. I didn't realize there was a bridge here, so I removed the capsule quickly, and after the procedure I realized that the capsule was not homogeneously circular and round. There was a bridge. It's very dangerous because if the capsule tears off, there may be big problems in positioning the lens in the sac, in the bag. In this case, I completed capsulorhexis and then introduced the lens. In 2014 at ESCRCS in London, Packard impressed us with these pictures. I thought that the laser cut was more sharp. On the left, you can see how indented the laser incision is, and below, you see what we do with manual capsulotomy. The edges are smoother. So in cooperation with the Histology Institute at my university, we also studied capsules after 1 year of femtolaser experience. Actually, there's no indentation, similarly to what Packard saw, but there's no homogeneity either. So it was thought that this indentation could also alter the resistance of the capsule. So when you put in a lens, the capsule might break. In 2011, this very interesting publication showed the resistance of the capsule using a dynamometer. They tried to pull the capsule, and they found that, in fact, capsules made with femtolaser are twice as resistant as with the manual procedure. Here, size and circularity were also assessed, and with laser capsulotomy, there were big advantages. The Italian school with Mastro Pasqua also found that circular capsulotomy is very fruitful. And here you have the overlap concept. The capsule has to rest on the periphery of the lens so as to create more stability. in the lens. So he compared femto and manual ones, and those with femto showed better capsular overlapping. Well, this has implications for all the IOLs that you have seen, and also multifocal IOLs, which can be implanted with greater confidence in terms of visual outcome. In 2012, we confirmed Friedman's data on the size of capsulorhexis. If it's larger, the lens tends to anterior tilting and myopic shift. Size, therefore, is important as well. This is my experience. This is our laser. I compared a group of patients treated with femto laser and one without, using my bimanual technique. I have a very short follow-up, 6 months only, but there are no differences in terms of visual acuity. There are differences in terms of surgical time and quantity of ultrasounds. I need to use more ultrasounds, and time gets longer with femto laser. However, I'm still in the training phase because I've been using it for just a few months, and I'm learning and I'm speeding up. I have less endothelial cell loss with femto laser techniques, and macular thickness is also very important. We had no cystoid macular edema or similar alterations, yet we found that there is a tendency to the macula showing greater thickness after surgery. I've had no severe complications. Well, severe complications are, for example, opening or perforation of the capsule posteriorly. I've only had this incisional alteration on day 1 at the site of laser incision. Well, this was a monoplanar incision. I do them biplanar now, so I've less risks. It's a safe procedure, as witnessed by this publication where residents were involved. They found that the risks are not higher, but mind you, in 46.8% of cases, surgery was done in expert hands. There were no difficulties with docking, and compared to the conventional technique, there were less complications. Final point, costs. Well, we calculated 425 euros per procedure if we do 1,000 cataract surgeries, and this is a cost that our national healthcare system cannot cover. Well, take-home messages. The accuracy and reproducibility of capsulotomy has a positive impact on the position of the implanted IOL. The cataract surgery with femto laser is a safe procedure also in patients where a multifocal IOL is implanted. Thank you.